So thank you for your patience in starting this, everyone. Good morning. My name is Barbara Boyer. I'm the Executive Director at AgeWise Colorado. And this morning we're having a conversation about the final chapter, which is near and at the end of life. And we would ask that you would all please mute your computer, keep your cameras off. It helps with the recording. And as soon as we do some brief editing after the recording is done, we will post this on the website so you can revisit it at any time. You should know about AgeWise because you joined us, but in case, I would remind you that we provide an essential service to older adults. We connect you with vetted service providers, which means we have checked their backgrounds. We ensure that they are legitimate businesses and that you will not be scammed. We keep our fingers crossed. It's not 100% guarantee. One never knows what may happen in life, but we do a very extensive process. If you're looking for something to do, we always have volunteers. And we are doing this webinar in cooperation and collaboration with a little help. They also welcome volunteers. So if you have some time on your hands, please think of us. This morning, we are having Dr. Maurice Scott, Scotty as he likes to be called, and Dr. Barbara Morris. I will let them, I'm not going to read this. You can go back and read it later, a little brief bio about them, because the most important thing is that you hear from our two presenters because they have some great information to share with you. This is our website. Go there anytime you need anything. There's also a phone number there. You can call me. And with that, I'm going to stop this because we want to hear from our presenters. So, Scotty, Dr. Scott, would you please start us off?
Absolutely. I have one picture that I would like to share to help
Okay.
frame this conversation for you all before I pass it to Dr. Morris. So, good morning, everyone. As Barbara said, my name is Maurice Scott. I go by Scotty. I am born and raised here in Denver, Colorado, and have been practicing palliative care and hospice care for the last, 13 years, I guess, here at the University of Colorado. So, happy and grateful to be the guest speaker today and answer any questions that you have. To frame this for you all from a palliative and hospice care perspective and how folks with serious illness may manage that serious illness moving forward, I thought we'd take a walk through what this pictogram or pictorial shows us. So anyone, certainly as people get older, sometimes, as people get older, chronic illnesses build up. They may have heart failure, they may have kidney failure that gets worse, they may have lung disease that gets worse. And then there's also kind of an increased possibility for cancers as we age. And ultimately, certainly all of us will at some point die here on this call and in this world. So when we're looking at the pictorial, I want you to take your eyes to the left side of the pictorial, and what you see is that the first part, the first triangle is prevention, and those are things where when we go to the doctor and they say, "Hey, we want you to take your statin medications." We want you to take your blood pressure medications, those kind of things to help prevent strokes down the line, to help prevent heart attacks down the line, to help prevent those kind of things. Well, once we get an illness, let's walk through heart failure, for example. Once one is diagnosed with heart failure, oftentimes they're not having any sort of symptoms. And it's in those stages that they're continuing to go see their cardiologist. They're continuing to get medications to help manage their heart failure, to slow the disease progression, to slow the disease progression so that folks can continue to live how they want to live. Well, as you see this middle line, you see the curve between the green and the orange on this line. As heart failure continues to worsen, people get sick and then they may end up in the hospital for a heart failure exacerbation, get some medications to help get that heart failure exacerbation together. They may have shortness of breath, and so palliative care may come in to help with symptom management, those kind of things. But recognizing that the patients really are still trying to get predominantly, as you see in the picture, more curative and life prolonging care. As people's illness continues to get worse and worse, oftentimes many of the medicines that the doctors will be using to slow the disease process start becoming ineffective, and the body just begins to poop out. And as the body is pooping out, you can see on this pictogram that palliative care may get more and more involved. Palliative care really is quality of life care. That's all it means. It's a group of doctors and nurses and chaplains and social workers who try to tend to the whole person and the whole person experience of their illness, from beginning of illness all the way till death. And again, on this pictogram, as you can see, the palliative care may be minimally involved when someone is initially diagnosed, but as the illness gets worse, as their symptoms gets worse, they're not able to perhaps care for their loved ones. Perhaps they're not able to work their job. Palliative care will come in and offer that added layer of support. As we continue to proceed through this pictogram, you can see that eventually all of these diseases overcome the body and they will kill us. And it is really not until that final stage of illness that we can really start talking about is, well, does hospice make sense? Hospice and palliative care are like first cousins, in my opinion, where palliative care, a little bit further upstream, people still want to go back and forth to the hospital if they need to. Where hospice care is when folks say, the hospital is not doing it for me. I hear that my illness is going to take my life. I hear that I probably have 6 months right around that is what their doctors are telling me in prognosis. And I want care to come to me at my house. I don't want to go back and forth to the clinic, spend my energy that way. And it's in that opportunity that there really is a way for the healthcare system to provide maximal supportive care at home through services like hospice. Hospice becomes like a new 911. If there's a crisis in the middle of the night, rather than having to go to the emergency department, you can call and a nurse can help you right then and there. If they're not able to help you over the phone, they'll come to your house or come to your nursing home, wherever you're living, to help get your symptoms managed, but not necessarily try to reverse the underlying illness. There's a nurse that will come and check in on folks once or twice a week. There's a nurse's aide that can come up to several times a week to help with bathing and to help with transfers and maintenance of dignity for patients. There's chaplains on the team to help tend to the spirit, social workers on the team who will come in and help access resources, to help process with surviving family members how the illness is impacting them, talk to children, if there are children involved in the family unit, around how this person is around how this person's disease is continuing to worsen and ultimately will take their life. And then, as you can see, hospice care doesn't end at the time of death of the patient. There's still, in the benefit itself, there's up to 18 months of post-death bereavement counseling that's available for patients for the patient's family and loved ones, as they're continuing to try to process and integrate the death of their loved one in a way that is really more adaptive than maladaptive, so that they can continue to move through the world. In this space, and I know that Dr. Morris is going to touch base on the medical aid and dying piece. What I would say overarchingly with regards to hospice is hospice generally does not provide the medications for medical aid and dying, but they are able to provide quite a bit of support for the patients who are interested in that, who have the medications available to them. Hospice and hospice nurses then support them along the way. And I'm happy to have a dialogue with you all and certainly with Dr. Morris about that and her experiences, because I speak in very generalities and Dr. Morris is going to come in and offer up some details. I think that palliative care right now is currently a happy accident. You know, you may not a lot of people know about palliative care. Not a lot of physicians lift palliative care up for their patients in time, and so people often thinks that palliative care and hospice are the same. And what I want to impart upon you all before I pass the mic is that if you are ill, if you have a chronic illness, palliative care may be beneficial for you. It certainly is worth a shot. And if you don't find the added layer of support to be supportive at all, then it's as easy as signing out of these programs. Again, you can continue to go see your primary care doctor, your cardiologist, your lung doctor, your cancer doctor. They're going to be giving you all those treatments. I'm just going to be the person, or palliative care is going to be the person to make sure that those treatments, if they're causing you nausea, let's get the nausea managed so that you can go to your family event. Let's get your pain managed so that if you want to go on that trip to wherever you want to go, to California, that you are able to do that. How I look at it is, let's not sacrifice today for tomorrow. Let's make it a both and treatment and symptom management. And with that, I'm going to stop share and pass it to Dr. Morris.
Thanks, Scotty. Great. And appreciate the opportunity, as always, to be here with AgeWise. We've collaborated often and hope to continue to do so in the future. Let's see if I can make the magic work here with sharing my screen. Give me just a minute. Here we go. All right. I presume you can see the slides okay? Barbara, are we good?
Yes.
Okay, great. Well, once again, thanks for inviting me. Always an honor to be here. As you heard before, I'm a geriatrician. I have several hats, as we all do. I have a small consulting practice. I help patients and their families with end-of-life issues, and as well as geriatric care management. I also have the honor of being one of the founding members of End-of-Life Options Colorado, and I'm currently president of our organization. And we have been really honored to partner with AgeWise on events and our websites and so forth. So we think the work is really important. And I want to echo, before I dig into this, I want to echo something that Scotty just said about palliative care maybe not being recommended or thought of early enough in the course of chronic or life-threatening illness. I think we see that a lot in the work we do. And I work with patients and families in all stages of as end-of-life approaches. And I really, I'm so committed to having people understand their choices earlier, because that's good for everybody, and then we don't have such an urgent crisis towards the end. So for our 15 or 20 minutes here that Barbara has allotted us before we get to questions, I'm going to tell you a little bit about our organization. I want to give you a little overview of what we do have available in Colorado, and Scotty has already alluded to a lot of those. And then I was asked to really focus on the details of VSED, which is voluntary stopping of eating and drinking, and medical aid in dying. And so we'll try to go through those as best as possible, and then I'll welcome your questions towards the end. So I'm not going to read this to you, but important that our organization, which was founded just over 2 years ago, aims to provide education and access for all Coloradans as to their end-of-life choices. And we think that education and access are really key to the process for folks should they face life-threatening illness. And in Colorado, it's been a really important issue, particularly ever since our statute for medical aid in dying was passed. But we have found in our work that it's not just about medical aid in dying, but all choices. And we want folks to remember that though we may be focusing on aid in dying because it's the newest kid on the block and because there are a lot of questions about it and a lot of needs, we do want Coloradans to know about all of their choices towards the end of life. So that's why we have this list. I'm not going to go through this in too much detail. It's been covered already. But just as a reminder, as adults in the United States with decisional capacity, we have a lot of choice. We can decide to continue medical treatments if that is what fits with our goals. We have the choice to stop or reduce life-sustaining medical treatments. So medications, chemotherapy, radiation therapy, surgeries, we have the choice, to decide what of those things we want or don't want. And then you've heard a lot about palliative care and hospice care care and the continuum there. Lots of continued misinformation about both palliative care and hospice care. And I think communication and language are really important. Hospice care is so supportive for patients and families towards the end of life. In the United States, we continue to have data that shows us that patients are being enrolled into hospice very late, like within a day or two of death. And I think those of us who've done this work for a long time recognize that having patients and families receive the support and care from hospice much earlier in the illness trajectory would be really important. Palliative sedation is not one that's brought up very much, but I always include it on my list. You know, when we are nearing end of life and we have potentially a lot of symptoms, there is a balancing act between our medications and the effects of our medications and what our goals are in terms of staying awake and alert and being able to communicate with our loved ones. And so palliative sedation is a technique that can be used for patients who are having overwhelming symptoms and where their goal is really to have those symptoms controlled, even if it means that they're going to basically be asleep during their last days and hours. So that's kind of a quick version of what we do have. And then we're going to really focus in now on VSED for short, voluntary stopping of eating and drinking, and medical aid in dying in our state. So important to remember this question about where can we receive end-of-life care? Should be an easy question, but it isn't. So in terms of our actual medical care, we can get our care from our care team. We can get our team from our palliative care team, as you've heard about from Scotty, which hopefully is in collaboration with the rest of the care team, that being your primary care person, your oncologist, your pulmonologist, your cardiologist, whoever is on your care team, and then hospice care. Important to recognize that hospice care, some people get a little confused about this. Hospice care is a program of care, not necessarily a site of care. So as mentioned, mostly hospice care is provided in the home. On rare occasion, symptoms can't be controlled in the home, and hospice care then is sometimes in a care center. And if a person is living in assisted living, independent living, skilled nursing, long-term care, hospice care as a program can be added wherever that person is living for additional services. So again, it's a program of care, not necessarily a site of care. And, you know, Scotty has described all the elements so well and so important. Hospice care itself, in terms of the actual medical care and the technical part, is in collaboration with your specialists at the end of life, particularly if VSED and medical aid in dying are going to be employed. So voluntary stopping eating and drinking, VSED, may be a newer process or program that some of you may have heard of, some not. You know, there's nothing in the United States that says that as an adult with decisional capacity that you have to keep eating and drinking. And that is part of why it has become an option for some patients where they feel that end of life is near, that their illness is overwhelming, that their quality of life is no longer satisfactory in the balance between quality of life versus, you know, symptoms and issues. And this is sometimes for patients who, for whatever reasons that we'll get into, don't qualify to consider aid in dying. And so VSED is a process that can be used to have a very dignified and peaceful death for patients who feel that they can't tolerate their current quality of life. I do recommend more information from the Compassion and Choices website, and they have a lot of great information, as other sites do as well, about VSED. We're going to go through just a little bit of that now. So first of all, why would someone choose VSED, particularly as opposed to what we think of as traditional hospice care or aid in dying? It's kind of falls somewhere in that spectrum. So these are patients who are sometimes terminally ill, but may not have the terminal diagnosis with the prognosis of less than 6 months that's required for aid in dying. They may have difficulty swallowing. Some patients have some early stages of cognitive impairment, which might prevent them from participating in aid in dying. And some of them have GI issues that would prevent them from making use of aid in dying medications. So this is just a broad spectrum of the kinds of patients that might be interested in choosing VSED as they near end of life. So what is it? Basically, it's a more formalized way. I think patients actually for decades, maybe centuries, have stopped eating and drinking towards the end of life, voluntarily and sometimes as a part of the disease process, where when we have very significant life-threatening illness, sometimes we stop eating and drinking as part of that illness. But VSED is a more formalized way that patients are saying, I know if I stop eating and drinking, this will lead to my death. And it can be in a very peaceful, dignified way in the home, but it takes a village for sure. Because as you can imagine, when we stop eating and drinking, our bodies are survivors and they fight. And so we start to have a thirst reflex, we start to be hungry. And it takes a concerted effort on patients, loved ones, and hospice team to support a patient's decision to stop eating and drinking. And as symptoms develop, as people become a little bit more confused or perhaps have some anxiety symptoms, it's really important for the hospice team to be right there supporting patients with supportive care as well as medications as needed. So VSED is a choice that some patients are using, and it can be a choice that's appropriate for some patients. It is hard, though, as you can imagine, and the time frame is variable depending on the starting point for patients. So depending on where on the illness trajectory patients are as to how long it can take. We tend to say this is a 10 to 14 day process if patients really completely stop eating and drinking. But as with everything in medicine, I'm always cautious when I give numbers because each of our bodies is very different and we go through this in different ways. Um, I guess we'll take questions toward the end. I know there are a lot of questions about VSED, but we'll take those together with the medical aid in dying. So I'll take a breath and try not to speed talk here. So what about medical aid in dying? I think this is our approach that has become of great interest as our statute was passed. But before we talk about medical aid in dying in detail, I do want to remind all of you, because I know you're all very interested in this, that medical aid in dying is a tool that we have now as end of life approaches and as patients are suffering and recognize that there is no cure for their illness and that death is approaching. But I want to remind all of us that aid in dying is not the only way to have a dignified and peaceful death in the place of your choice. And I emphasize this because as aid in dying has become more visible and people focus on it, we don't want any of us to feel like it's the only way to have a peaceful and dignified death. Because sometimes aid in dying, as you'll hear, doesn't work out for some of us, and we need to turn to our other choices. And so I just remind myself and all of us how important that is. So it's an important tool, one we should know how to use, but it's not the only tool. And then the other reminder, which some of you are aware of, is that we'll talk about the qualifying process for aid in dying in just a minute, but about 30% of patients who go through the qualifying process, all the steps I'm going to show you in just a minute, and are kind of cleared to get a prescription for aid in dying, will actually not use the medication. So that's a very interesting thing. We have some data about that. Our understanding is that patients feel a great relief to know that they have that choice. And sometimes their anxiety and suffering actually decreases after they know the choice is possible, and they won't make use of the medication. Sometimes patient situation changes medically. So even though they've gone through the qualifying process, things change and it's no longer appropriate. And so that's another reason why patients might not use the medication, even though they've been approved. So in 2016, and many of you were probably in Colorado at this time, the Colorado voters passed by a very large majority a ballot initiative to approve what's called the Colorado End of Life Options Act. It went into effect in January of 2017. It defines aid in dying, qualifications, and some reporting requirements. I think it's very important to notice, though, that the statute does not legislate the details of aid in dying in terms of what medication we use, in terms of the dosages, in terms of how we practice. And I think that's really important because I think as clinicians, that's what we need to be working on. But it does define a rigorous set of steps for patients and their providers to follow, and that's to protect all of us, to protect patients, their families, as well as their care teams. So really important. I'll just mention as an aside that in Colorado at that time, we didn't have a nonprofit organization working on these issues. Those folks who were working to get the law passed were working really hard. They had spent a lot of time, but they had not formed an organization. And we realized about 3 years ago that it was really important to develop an approach in the state, because despite the law being passed, we knew that there were a lot of issues about information, education, and access. And that's why End of Life Options Colorado was born. There are some additional things about the act that are important. It provides immunity for those acting in good faith. It does allow for healthcare providers to decline to participate. It allows for health systems to prohibit their staff from participating. However, if a health system is going to opt out completely, they do have to notify patients in some sort of policy that's in writing. And if a healthcare provider, and I'd add, or a healthcare system is unable or unwilling to participate, they are required to cooperate with transferring patient care, making sure records are available, and so forth. All right, this looks overwhelming, I know. I always say to people, whoa, then why'd you do a slide like that? But we'll get through it. What I always say when I'm working with loved ones and patients is this process looks overwhelming if you see it, but we are able to get through this process actually quite efficiently. And it's an important process, and we do our best to make sure that we're following the rules for many reasons. So first of all, who's eligible for aid in dying in Colorado? Well, you got to be over 18. You need to have a terminal illness with an expected prognosis of less than 6 months. And I'll come back to the terminal diagnosis part in a moment. You have to have decisional capacity. You have to be able to self-administer, and you have to be a resident of the state of Colorado. So those are pretty important requirements. Terminal illness, decades ago, if you'd asked me as a resident whether I could tell what a terminal illness was, I would have said, oh, sure, that's easy. Turns out it's not quite so easy. But for clinicians, we have to use our best information through speaking with the care team, looking at records to understand whether in our best estimation, someone has a life-threatening illness that will result in their death within the expected 6 months. And we do our best at that. And I would say it's an inexact science, but we have to use our best information to determine that. Patients have to have a decisional capacity, as I mentioned. Well, what does that mean? We've learned a lot about this, and there are some tools to help us. But basically, it requires that you have to understand your diagnosis and your prognosis. You have to understand what your choices are for treatment that you might be accepting or declining. You have to understand what aid in dying would result in. And we really have to make sure that there's no evidence that a patient is being coerced. So I know I'm going to have questions in the chat, as will Scotty, about what about memory and cognitive impairment and aid in dying. It's a complex question. Patients have to be able to understand the things I've just defined, but they don't have to have a perfect memory to do that. And I think that's really important as we assess who is eligible for aid in dying. Self-administration is really important. Every jurisdiction in the United States requires that the patient self-administer. They can have assistance in terms of mixing of medications, in terms of someone holding a cup or helping with a syringe if it's going into a tube in the stomach, but the patient has to be able to self-administer. And our laws require that the administration be somewhere through the GI tract, not through IV administration. Just as reminders, person makes the decision, nobody else. There's no requirement to take the medication, even if you have it in your home. That's, again, an individual decision. And the death certificate does not mention aid in dying as the cause of death. The cause of death is of course, the terminal illness. So the process sounds complicated. As I said, if we stay very organized, we can do this quite efficiently. The law requires 2 requests for aid in dying. We recently had a change in the law, so our waiting period is only 7 days now. There has to be an evaluation by an attending provider and a consulting provider, and then a written request. And once these have all completed, the prescription can go to the pharmacy. I want to highlight that in August of this year, Governor Polis signed changes to our law, which changed the waiting period to 7 days and also included advanced practice nurses as providers for either the attending role or the consulting role. So that's been an important change for all of us, is to include more providers in this process, particularly in parts of the state where we really have access issues. All right, so these are the updates from last summer, shortening the waiting period to 7 days. We also have a waiver now allowed if the patient is likely to die very quickly or their suffering is overwhelming, then the clinician can use this waiver to move things more quickly. Adding the advanced practice nurses, as I mentioned, there was consideration of getting the state residency requirement dropped. That did not pass. So at the moment, you still have to be a Colorado resident to make use of the law in Colorado. And again, he actually signed, this is not quite right. He signed it in August. The legislation was passed in 25. I apologize for that. Before we turn to questions, I want to talk a little bit, though, about what is aiding dying about in practice, not just the law, which is very important, which is why I've told you about it, but what is it to really participate as end-of-life years? And for me, this is really important. This is where art and medicine intersect, at least in my life. So as I told you, we can get through the spreadsheet of 2 of this and 1 of that and another of this, but most importantly is developing the relationship with the patient and their family and their team, and making sure that the patient's needs and goals are being met. And so we do that in a very defined way. At least in my practice, initial patient assessment, of course, is critical, determining qualifications and appropriateness of aid in dying. Hospice enrollment, this is a really important thing that I'll highlight. Hospice enrollment is nowhere in our law that you have to be in hospice to make use of aid in dying. But those of us currently participating would argue that for the vast majority of patients, very rare exceptions, hospice is really critical to patients and families and providers having the support they need for the aid in dying process. Scotty alluded to the issues about hospice participation. We don't have the time to go into all the details of why there are issues there, but just to say that there is a federal law that was passed in the 1990s that prevents federal dollars from being used for what is called euthanasia and assisted suicide. Our law in Colorado actually refers to aid in dying as aid in dying, and it says it's not euthanasia. But the legal folks have been very nervous about possible sanctions for hospices who, as you know, receive a lot of funds federally from participating. So in Colorado, we have a spectrum of hospices, from some hospices who are not supportive, don't want patients who are considering aid in dying, and that's rare, I think, to the other end of the spectrum where we have full participation by hospices in terms of talking about aid in dying with patients, helping them get the care they need. We have very few hospices where the physicians are actually prescribing. I think we have 1 or 2. And in the future, we hope to see that spectrum move more towards full participation by hospices and their care teams, but that's not where we are in Colorado right now. Pharmacology recommendations are changing. Most of us try to keep up to date with what the best evidence is about the pharmacology recommendations, and perhaps most importantly is ongoing assessment after the qualification process has been done. So for some patients and families who I work with, it's very quick. We do the first request, the second request, the patient is really ready because of their suffering and other issues, and they may ingest right after the qualification process. But we have quite a group of patients and families, the patients who want to know that they have this option. They want to get through all the paperwork and the qualifications, and then want to know that they have that choice. And for those patients, at least my practice, and I think my colleagues' practice, is to stay in very close touch, usually seeing patients every 2 to 4 weeks. What's going on? What symptoms have changed? Have you chosen a date? To really keep in touch with what's going on. On very rare occasion, the medical situation changes during that time, and we have to sometimes change course as to what's appropriate for the patient. And then critical is collaboration among all the members of the care team, and really this should say the care team and the family and the loved ones, which are all included. Communication on a regular basis is really important to helping patients achieve their goals. So what about restricted settings of care? As I mentioned, the law does allow health systems to opt out of their providers providing aid in dying in their facilities. That's been interpreted in a variety of ways, which we will not get into today, but it is important for patients and their loved ones to even know if their care system is going to participate if this issue comes up for them. As I mentioned, hospices have a variety of policies regarding how much they will participate. And I'll call out federally qualified health centers here in the same way as hospices have interpreted the suicide and euthanasia law, assisted suicide and euthanasia law, and our FQHCs in Colorado have interpret this in different ways. So some of them have policies that allow their providers to participate and some don't. The main reason I bring this up is I think it's important for patients and their advocates to know what their healthcare systems and their doctors are doing or not doing, so that they can be aware should this become an issue and can receive care where they want it. I think that that is a very important issue. And so that's why I bring this up. And some patients will actually talk with their primary care and specialty folks long before they might have this issue, just so they understand where they might be able to get care. Before I go to this summary slide, let me back up for a second and say that I think it's important to understand what your choices are. So in my experience, my first choice for patients and their loved ones is to have your care team take care of you, either through what we consider traditional hospice care, possibly VSED, or possibly aid in dying, if your care team is able to do that. To me, that's first choice. If your care team is not able or willing to do that, in my opinion, then the next choice is someone in your community who's able to help. So a consultant practice like myself, Denver Health has a big program, Kaiser has a program for their patients, University has a program. So someone in your community who you can know in person who can help you. So that to me would be the second choice. And the third choice, which we are making quite a bit of use of in Colorado right now, is virtual care through telehealth, because we do have situations where there's no one in a person's community who can provide this care, particularly in more rural aspects of the state. And so we do participate by doing some of this care virtually, getting the qualifications done. Of course, we still highly, highly recommend having local hospice organizations there for support and so forth. So really important. So in Colorado, we have many choices, and they include aid in dying and VSED, but they are not the only choices for having a peaceful and dignified death. The End of Life Options Act is detailed, and we have to follow it. And but when we do, and if it's the right choice for patients, then aid in dying is certainly possible in Colorado. I think that evidence-based care gives clinicians, patients, and their loved ones the opportunity to make use of aid in dying and to have a dignified and peaceful death. And not to underestimate that we do have access issues in Colorado. We have some barriers, both because of geography, because of clinician education and restricted settings. And those are areas that our organization in particular is working on. So I will stop at that. Barbara, I think this information I hope will go out to attendees in some format with some links for your information, and happy to take questions.
I want to back up to Scotty, if I may. Who determines palliative care is done, it's time to go to hospice? If I were in palliative care and actually was even wanting to choose end of life options made, um, would my doctor do that? Can I say, okay, I'm at this stage?
So very, very good question. I would say, first and foremost, you as a patient and any of you can always choose to engage with palliative care. And so if you have if you have, let's say you have a cancer and your doctor is not bringing palliative care up, you can say, I want this as part of my treatment team. And so please feel empowered to do that and for that. Once palliative care gets involved, how they would help you in guiding some of your decision making is really getting to know who you are as a person outside of your illness, what your values are, what you're hoping to get out of some of these treatments. And then they may make recommendations for when you're getting to a point where hospice will help you better meet your goals, then palliative care plus chemotherapy would help you meet your goals. And so while they give a recommendation, it would be driven predominantly by you as the patient to say, this is what this is the path I want to take. I think what we've noticed is that without patient education like this, providers not often enough are they referring to palliative care until patients are very, very sick, maybe at the last line of chemotherapy. There's no other chemo options, and that's when the providers will say, get palliative care involved. But as Dr. Morris and I are in agreement on, that's far too late.
Thank you. So is palliative care time kind of when you might look at also going into assisted living or long-term care? I would presume actually long-term care.
That's a good question, and not necessarily. I think when I think of assisted living and long-term care, those people tend to go in those when they need more help with their activities of daily living or their instrumental activities of daily living. So let's say, managing a checkbook, preparing meals, showering, those kind of things. If they need more assistance, that's when they would go into assisted living or long-term care. But that is separate from when palliative care can be involved. There's a lot of patients who see palliative care and they're out and about living in the world, still going to work, still doing their job, still being able to prepare food. And so for all of those patients, we would want palliative care as well.
Thank you. We have another question. Can you please clarify if palliative care is an option while an individual is still pursuing getting better? Or is it when one has decided not to pursue any more curative care?
So it's an option when people are still pursuing getting better. And I would say it's an option to take advantage of, because these are the people who are experts in getting your pain under better control, getting your nausea under better control, which could be a side effect of the chemotherapies that you're still getting, or it could be a side effect of the illness itself.
And we have our provider CPA on this call. And Rick, I'm gonna let you just talk if you would, and just say what you have in the chat, because maybe not everyone goes into the chat easily about long-term care and tax returns and all of that with hospice.
Yeah, I was just going to say that usually it's always good to have a POA in place. I've seen situations where people don't have someone in place quickly and they need that help on the finance and tax side of things and getting things done there, because you don't want time to go by and those things are not being taken care of. But then also when the individual passes away, who's going to be the executor or that POA that's going to take control and finish those matters that are important. And then there have been times too where I've seen people pay for these expenses when they're in the hospice care. Most of the time, those hospice expenses can be itemized. But what I've seen is people take the money out of the bank first from the individual, and then they tap into their investments. But if there's a tax benefit of reducing that income, it's probably best to take it from a qualified account, such as an IRA, 401k. And then you can write all that off with the hospice care that's going into it. So if you have more questions or thoughts, just give me a call, email me. I can go from there.
Thank you, Rick. And we have another question. Can you give an overview of how Medicare and Medigap cover palliative and hospice care? I'm not sure. That's a question the doctors can answer.
Well, we know some of it.
You know some of it. Yeah.
Okay, go for it.
I'll give a stab on hospice care. I'll let Scotty do the palliative care if that's okay. So, hospice care is a Medicare benefit. So that's important, or at least it is right now. That's all I'll say. We don't really expect any changes to that. Hospice care, and I should have said this before, it aligns with, in some ways, how we assess aid in dying. It does require a terminal diagnosis with an expected prognosis of 6 months to be certified for hospice care. And again, it's medical judgment, best judgment on the part of the team. And then patients are sometimes recertified depending on their situation. You all have had friends and family members who've been in hospice for more than 6 months, but we won't get into that. So hospice care is basically we think of as a carve out somewhat kind of in Medicare. So once you are enrolled in hospice, your care is the responsibility of that hospice program, as long as that care relates to your underlying terminal illness. And they cover more than what a lot of insurance covers traditionally. So it covers equipment in your home, oxygen, a hospital bed, a commode, that kinds of things. And they arrange, it's very comprehensive care. So they will have that delivered and so forth. They will arrange for the medications that are related to the terminal diagnosis. And of course, the services that Scotty has already mentioned. And these are covered generally in full by Medicare. And the Medigap question has to do with whether you have a supplement or a Medicare Advantage program. And so the coverages should be similar. They're not exactly the same. If you're in a Medicare Advantage plan, as an example, you may be required to use a hospice program that they are contracted with. And so the details of that can get complicated, but in general, for someone has a certificate of terminal illness and is admitted to hospice care, it is a wonderful program, not only in terms of what we've described, the services, but in terms of some of the financial aspects of that. So, Scotty, you want to fill in about
I would
palliative?
add, yeah, for palliative care, generally it's based on whatever insurance you have, palliative care visit would be the same copay as if you were to see a specialty provider. So if it's $20 copay on your insurance to see cardiology, it'll be a $20 copay for palliative care.
And someone asked about APOA. Do you want to take that? I can answer that. I'd welcome our experts, our doctors.
So as Raina said, it is power of attorney, and there's both a medical and financial power of attorney. Rick was alluding to the financial power of attorney to have access to accounts to be able to help manage the finances for patients. And then in my world, I focus a lot on the medical power of attorney for patients who come in and they're fuzzy. They're not able to make decisions for themselves. They're cloudy or not sound of mind. And then the medical power of attorney is the point person that the doctors will go to help make decisions on the patient's behalf.
And there is also, I can't recall the name of the legal document. I just had my will redone. And I specify in there how long I want to be kept alive in the case of a trauma. For example, if I were in a terrible car accident or something like that, so that your family and whoever has the medical POA knows what your wishes are.
Yeah, so that'd be like almost like a living will, I think is what you're
Yeah,
talking
yeah,
about.
there was another name to it as opposed to living will this time, but
Hmm.
that's always a good thing for all of us to have.
Yeah, thanks for the segue, Barbara. We should have both mentioned this. I sometimes we get into the details. I think these forms, whatever all of you choose, whether it's a living will, a power of attorney for healthcare, both really important. The most form may be what you're thinking of, Barbara, where it goes through CPR, ventilator, feeding tube.
Right.
Might be the 5 wishes. It might be the most form, which some of the attorneys have taken to having folks fill out. I think all of that is incredibly important, but just as I was talking about hospice care in the US being, late in the game, we really all need to buck up and have these conversations with our loved ones, because I just have to put in a plug for that. The forms are really important. They are. I'm not belittling that, but what's really important is that your loved ones, your advocates, whoever might have to help make decisions for you, if you are unable to make decisions for yourself, can hear your voice in their ear saying, I don't want that. Or, yeah, I would want to be on a feeding tube for a couple of weeks. Um, they need to hear your voice. For one, you want your wishes followed. And for two, my experience with families and loved ones in this situation is that it gives them great comfort to know that they're following your wishes. So please, I know it's hard, buck up and have that conversation with your loved ones.
You
I
know,
just want to amplify that. I think the conversations are the most crucial because these forms have 2 or 3 options, but what we know is there's innumerable possibilities of what can happen in the hospital. And so to have a conversation around what's important to you, what your values are, what makes a good quality of life, those can be good North Stars that you can, as a power of attorney, lift up to the doctors, to the medical team, and say, this is the North Star. And then the doctors can help guide you to get there, or they'll be realistic and say, we're not going to get there.
we have done a number of webinars for our audience. If you go back and look at webinar recordings that really go into the specifics of all of the legal documents we all need to have in place. That eliminates that burden on our adult children so much. And then they follow our wishes.
May I make one more point for here in the state of
Please.
Colorado?
Yes.
So here in the state of Colorado, if you don't have a medical power of attorney, there's not an automatic hierarchy of who the doctors should go to, where we're considered an all-interested party state. And so essentially what that means is no medical power of attorney, anyone who has an interest in you and your well-being, that could be family, friends, it could be your barber, they all have an opportunity to sit around together and determine who that decision maker will be. And that can make things more complicated and more dramatic in what it already is a tense situation.
Thank you. And someone just noted, Sylvia, thank you, that she's found it useful to complete her health insurance company's form to authorize name other individuals to call or get insurance claim details for her insurance coverage. That's a good point. I guess I have another question. I don't see. Feel free, anyone, put it in the chat if you have a question. For someone who has been diagnosed with dementia, and maybe we all think we're in that. I'll speak as if I have dementia. I've been diagnosed. I've progressed and I am worse than I was. But I have those moments where I'm very keenly aware of my surroundings and I could pull it off, for lack of a better term, with a written document and talking to you, Barbara, or someone that's doing similar work. How do you make sure? I mean, I can see family members getting upset if there hadn't been a previous
Yeah.
conversation with them.
Yeah, so I'm going to suggest just that age-wise as a whole, webinar on this issue because it's huge. I'm not trying to get out of answering your question, kind of, but in terms of aid in dying in particular, what I said, the two things that are most important is one, you have to have a terminal illness with a 6-month prognosis, and you have to have decisional capacity. Okay. So if you have, let me back up, I'll go backwards. So if you have dementia alone as your illness, I mean, then by the time the dementia is considered terminal, those of you who are familiar with the fast stages of dementia as an example, by the time you get to 6 or 7, where you don't recognize anyone, you're only speaking 1 or 2 words, you need assistance with everything, all the activities, it's pretty clear you would not have decisional capacity at that point. So dementia alone is usually not a terminal illness that a setting in which we can use aid in dying. Just make that as kind of a blanket statement. But that's not the situation we usually see. The situation we often see is someone who has an additional illness, lung cancer, a terrible neurologic illness, pancreatic cancer, all the other kind of things you think of, where they have that in addition to some memory impairment. All right. So we know that they might have a terminal illness with a poor prognosis, and they have some memory impairment and an early or even a moderate stage cognitive impairment. And then the question is, can those patients partake in aid in dying? And as with everything in medicine and ethics, I will tell you, it depends. It depends on whether they can understand the decision at hand, whether they can keep that decision, how the family is doing with that. And so it becomes, we deal with this very regularly. But dementia alone is almost never going to work as an aid in dying for an aid in dying day. Now, there's a lot of work being done all over the United States because this issue is very common about what's called advanced care directives for memory impairment and dementia. And you can certainly look at the Compassion and Choices website and other websites about the work being done where people are making very explicit advanced directives, even some videos of, if I'm at this point in my memory impairment and my dementia where I don't recognize my family, I need help for everything, then I want to, implement VSED in that situation. And so there's a lot of work being done for folks who have very strong feelings about not wanting to progress in their dementia. So again, that could be a whole nother webinar that we could participate in. And Scotty, I don't know if you have other thoughts about that.
No, I think you comprehensively answered it.
I really want to thank both of you. This is a very hard subject for all of us to deal with, and I appreciate the efforts that you've made with us and the information you've shared.
Thanks for having us.
Yes, thank you
Take
so
care,
much.
everyone. Stay safe and warm. Bye-bye.
Thank you. This will be
Bye.
on our website in about a week. Thank you all. Bye.
Bye.